Okay, and welcome everyone to our Multi-Modality Imaging Conference. It's a pleasure actually to have a wonderful topic today, myocardial viability. And what you have is you will have a treat of three speakers, Dr. Mouaz Al-Mallah, who's just joined us to head our PET program, Dr. Dipan Shah, and myself, who will be talking about all the various modalities to evaluate myocardial viability and the importance of that. Now, it is interesting to go back in time a bit as to when this concept of myocardial viability came on board. And actually, it is Dr. Rahimtullah back in the 80s who observed that after a bypass surgery, and this was in the early days also of bypass, that some individuals who have significant depression in ventricular function after an LV angiogram, post nitroglycerin, or after the operation 8 months later, ventricular function has improved significantly. And thereabout comes a concept of viability, meaning not every ventricular dysfunction that is thought to be irreversible would be irreversible. And in general, we're not going to talk about all the pathophysiology of it, but I think in general, you can have two types of reversible myocardial dysfunction. One, which was worked on for almost 20 plus years, which is myocardial stunning. After a brief period of ischemia, that ventricular function may improve significantly, usually within just a few days and even early on, and maximizing recovery within a year. And the other is the chronic ischemic dysfunction, where you have significant coronary disease, no acute coronary syndrome, but ventricular dysfunction, regional or global, that after revascularization, with either PCI procedure or coronary artery bypass surgery, gradual improvement in ventricular function occurs. And since it is an imaging conference, it is really important for us to address some of the historical as well as the available modalities for us to look at myocardial viability. From the electrocardiogram, I think we'll talk a little bit about that, to echocardiography and its modalities, and that's what I will be covering. Dr. Al-Mallah will cover nuclear techniques and PET, and Dr. Shah will talk about CMR technology. Now, for us to kind of put it in perspective, I know I'm not showing you pathology, I'm going to show you a schematic of pathology, is that in ventricular dysfunction, and here we're talking about with ischemic heart disease, that if you look at the pathology of these ventricles, you have actually a quite wide variety or spectrum, from the almost completed infarction on the right side with still some remnants of myocardial cells, to a nice mixture of a scar, which is usually subendocardial, but also some areas of viability still remnant, to areas of where the myocardial cells are rather intact, I would say, but maybe the capillaries are decreased a bit, and you may have some different in morphology, but more importantly at the cellular level, differences in beta-adrenergic receptors, cytokines, and different other things that may give you ventricular dysfunction. And the pathophysiology, if we kind of put it together on chronic ischemic dysfunction, is that most likely it's a repetitive stunning, meaning every time an individual either walks around or stressed or whatever it is, and coupled with significant ischemia, that you don't have as much reserve. And with that, so you have bouts of repetitive ischemia that teleologically the myocardium really reduces its function to have less oxygen demands, if you will, or consumption in this situation, but that's rationalization of the situation. But that's what really happens in this. So most likely it is a repetitive stunning phenomenon that causes, in the extreme, if not treated, an infarction or significant dysfunction that gradually recovers over function. So if we put it in the clinical context, why is it important to evaluate viability? Number one is that for the trainees and everyone, is that actually it exists. It is not a concept, it is true. that ventricular dysfunction in ischemic heart disease can significantly improve after revascularization. Two is, so on the first one is identification of these individuals. Clinically, most often, if somebody has ischemia or angina or other things, you're not going to just think about viability, but I think it's important to keep that in mind. Two, yes, we think most of the studies that you're going to see are recovery of function at rest, although we've done some work as to what happens to function after recovery during stress, and the reserve of this heart becomes almost normal, which is important from a exercise capacity and functional capacity. But to be truthful, in current technology of revascularization, where you could even off-bypass revascularization and all the complex PCI procedures, that the most important portion of it is whether an individual would go with severe dysfunction for a VAD or transplantation versus revascularization in high-risk individuals. And I think this is really the crux of this area of viability. When you have high risk of an intervention, and you have to decide whether to go for the high risk or the alternative, which is drastically different, either VAD or transplantation. So overall, these are the indicators of viability. Angina is clinical, but also still very important. Lack of Q waves, and I think that's important as opposed to the presence of Q waves. So lack of Q waves tells you about something about viability. Hypokinesis as opposed to complete akinesis. Preserved thickening is important. Contractile reserve, and that's where echocardiography comes to play. Radionuclide uptake, we will talk about that, and this is for regular nuclear or thallium or others, more than 50 to 60% uptake. Inducible ischemia, always important because it tells you part of the pathophysiology is if you have repetitive ischemia, this is where conceivably you may have recovery of function, or no or minimal delayed enhancement on CMR tells you also about revascularization. And among all these modalities that we talked about, really CMR is the only one that visualizes this area of viability or lack of viability, as opposed to all the others which infer it one way or another, either metabolically or with contraction or contractile reserve. This is data from our institution looking at Q waves. So for fellows and clinicians, if I have somebody with ischemic heart disease and heart failure, but no Q waves, your specificity for viability is actually quite high, is in the 70s. Now, the presence of Q waves doesn't tell you lack of viability, right? But the absence of Q waves tells you a lot about viability. So if you see an electrocardiogram with almost normal electrocardiogram in somebody with heart failure as well as ischemic heart disease, you could almost take it to the bank with a high likelihood of a viable myocardium in this situation. Dobutamine, and I think our center as well as many others have worked with dobutamine to look at contractile reserve in these individuals. And contractile reserve, as you would think, initially is counterintuitive. Said if you have severe reduced coronary flow, how do you have contractile reserve still when I give an inotropic agent? And it's interesting because there is some downregulation because of either lack of beta-adrenergic or less sensitivity to beta-adrenergic receptors, as well as cytokines and others that may alter contractility and reduce contractility. So you may still have reserve at lower doses of dobutamine. And if you go to higher doses of dobutamine, obviously it will cause ischemia. And so this is the protocols for ischemic heart disease in dobutamine can vary, but the most important things are the lower doses for dobutamine. In our investigations, we've used even starting at 2.5 to prime the myocardium, 5, 7.5, et cetera, as opposed to jumping to 10 and 20, et cetera, early on. Why? Because you want to look at the subtleties of what happens during inotropic stimulation. So, and this is a case here for you. You could see the areas of abnormality versus the areas of that enhances significantly with dobutamine. We did a titration protocol many years ago when Imran Afridi was with us. He's now in Dallas, and this is, my goodness, 20 plus years ago, that you could see not every dose gives you the maximal contraction of the butamine. So it's a titration curve from 2.5, 5, 7.5, etc. The vast majority of what you see contractile reserve before seeing the ischemic episode is usually about 7.5 times 10, so between 5 and 7.5. And actually, if you use both a combination of 5 and 7.5, you're going to see the vast majority. Some individuals will start actually being ischemic at 7.5. That's why in our protocol, we use rest, 5, 7.5, and maximal if we're going to go to maximal and safety is there without major arrhythmias. So if you look at what happens to this myocardium, this is what we've classified back in the early days in our investigation as to what the dobutamine responses are. One in green is biphasic response, which is the classic for viability, meaning an improvement at low dose and worsening at high dose. Tells me that there is contractile reserve as well as I'm producing ischemia. So the likelihood, as you will see, of recovery function is very high. Worsening, basically, you have no contractile reserve. If you have hypokinesis, the gut just gets worse, and this is, the minority of the time. You may have sustained improvement in areas, which tells you that you may have had an infarction or something else, or cardiomyopathic response or tethering, that you can continue improvement without causing ischemia. And you would think that if I revascularize, my likelihood of recovery of function is not very high, and no change is in about another 35%. So what's the likelihood of revascularization if I see regionally what these responses are? Biphasic, as we talked about, in green has the highest predictability of recovery of function. Next is just worsening. No change or sustained improvement is a low likelihood. It's not nil, but it is a low likelihood of recovery of function. Now, you could combine the two to be more sensitive, if you will. Any improvement will give you a sensitivity of about mid-80s with a specificity in the 60s or 70s. If you want to be really specific, and I think that really tells you of, in any of these modalities, you want to think about sensitivity and specificity and predictive accuracy when it really counts, meaning this is a dangerous procedure for whatever this individual is. I want to be much more specific, actually, for recovery function as opposed to sensitivity. So you have to play it well from a risk-benefit ratio to a particular patient. So using biphasic response is very specific. If I use any improvement, it is more sensitive and less specific. Now, briefly, I'm going to mention that, yes, besides qualitative things, you could quantitate it, and these are using strain imaging as well as strain rate. This is data from Tom Marwick, again, a few years ago, and most of these investigations are really relatively old compared to new because the field has been really well developed. So you could look at strain and strain rate, and I'm not going to bother you with all the details here to tell you that if you look at multivariable predictors with dobutamine, augmentation of wall motion, and this is qualitative interpretation, the odds ratio are very high with significance. Strain rate and change in strain rate, yes, they're still important. So you could add quantitation to the qualitative information, but qualitatively, I think it's pretty good comparing the low doses versus the high dose and rest. Another thing that's important, and I think probably Dipan will talk about that too, is thinning of the myocardium. Now, we've discovered after MRI that not all thinning means non-viability, but still in the vast majority of cases, a very thin hyperechoic myocardium, just like you see here in the pointed area, tells you that the properties are different. Most likely there is scarring and fibrosis. That's why you have the hyperechoic portion. And it relates to nuclear uptake, so it relates to viability, and also it relates to a prediction of recovery of function. So this is an investigation here we've done, again, a few years ago. Jocelea Schweig, who's back in Brazil, did this work. And you have, in the same patient, rest redistribution thallium versus echocardiography looking at thickness. And basically, it's the same distribution. And you would expect that the thinner the myocardium, the less uptake you have and the less viability. And indeed, that's what you see here. These are the ROC curves for thickness versus rest redistribution thallium. And the cutoff usually is about 6 millimeters or so, or 5 or 6 millimeters, below which you have very low likelihood of recovery. Now, that low likelihood, again, from Dipan and Ray Kim, tells you it's not really nil. And if you want to know more about it, obviously, you're going to need to do an MRI to take a look at whether indeed it is predominantly scar, yes or no. So you could use all this together to try to improve your predictive accuracy, looking at contractile reserve as wall thickness, and actually you could use them in the same test. So you're qualitatively looking at the thickness of the myocardium in addition to what really happened during dobutamine. And last few slides here, perfusion. I'm not going to belabor the point. We've done a lot of work, and other people have done a lot of work on contrast echocardiography. Bottom line to me, although it is a different mechanism, it's very similar to nuclear rest redistribution thallium, meaning sensitive and a little less specific, although the mechanism is very different. The mechanism here is telling me about the capillary, the density of the capillaries in this dysfunctional myocardium. It is not uptaken by the myocardial cells as opposed to nuclear, where actually you depend on the viability of the residual myocardium to uptake the thallium. So yes, you can quantitate flow, and basically flow, and this is, we'll talk about that during contrast, but these are various ways of looking at flow in addition to volume of blood, and basically the ones that recover are in between. Completely normal myocardium versus the myocardium that doesn't exhibit any recovery. And we were able, when Sarah Shimoni, she's back in Israel now, did a lot of work actually doing biopsies in patients and looking at viability. We're not belaboring you today with that. But if you look at qualitative MCE, which is myocardial contrast echo, quantitative is very similar to rest redistribution thallium, which is much more sensitive, less specific. If I go in the same patients for dobutamine biphasic response, much more specific. Again, you could use this whichever way you want it from a clinical decision point of view. And dobutamine echo, any improvement, again, more sensitive and less specific. Last, interestingly enough, I don't know, you could argue that as diastolic function. And we've had opportunity to look in the same patients about diastole. If you look at a pattern of slow relaxation versus a restrictive flow on the right side, interestingly enough in these patients, and we've had biopsies on them and so many other things, is that if you have slow relaxation, although it is load dependent, it relates somewhat to viability. And this is from Yonki Young, who I think is still in Texas somewhere, close to Corpus Christi. I don't know if he moved lately. But when he was with us, he looked at this relation of deceleration time versus contractile reserve. And basically the bottom line to you is if I have a slow relaxation pattern, it indicates much more viability than if I have a restrictive pattern, although it is load dependent. And the relation of diastolic function, interstitial fibrosis, the ones who have a deceleration time that is rather long, more than 150, have less interstitial fibrosis, better contractile reserve, better change in EF, and they stay in the ICU less, and they have less need for death or transplantation. So in summary, for echo-related parameters, one is that contractile reserve is a good marker for myocardial viability. You could quantitate it, but you could use it in a binary fashion, if you will, meaning a biphasic response, if you require that, is much more specific for recovery. So if I have somebody who's sick and you're wondering about it, it will tell you a lot about viability. Ischemic induction with any modality, even with nuclear or whatever it is. If I have ischemia, it tells me that I will most likely get better after revascularization. So ischemia with dobutamine or others is important. Thickness, most of the time it is predictive, although at times it can be thin but still viable. Contrast echo, similar to nuclear techniques, if you will, but most people are not using it as much nowadays because of, lesser reproducibility and just more tedious than all the other modalities that we have. So, yes?
If you could go back to that slide of Young very quickly. So I think this is a slide, I remember, yeah, that slide, yeah, the other one, next one. Yeah, that slide, I think is a great slide because of how concepts are appearing on different, how different techniques are found On your right, what you see here is the number of viable segments versus the deceleration time. And other slides have shown also similar relation with improvement in EF. And usually it takes about a quarter of myocardium to be viable to have a global impact. You saw that in the early papers. It's interesting that the MRI and these PETs and everybody is agreeing on that. So it's nice to see, no matter how you look at it, that there is this threshold of amount of viability to have an impact from a global point of view in the function, which is a very nice finding that has been agreed upon by more than one technique.
And again, if you use more specific criteria, you will need larger, lesser, if you will, numbers. If you use a nuclear technique, let's say rest redistribution thallium, like Ragosta and George Better have used, it's a higher number because if you are more specific and less, more sensitive and less specific, then your recovery prediction is lower, right? So I'm going to stop here and let Dr. Al-Mallah take over and talk about nuclear techniques. And we'll have a time to discuss all these hopefully at the end.
Right, so Dr. Zoghbi just set the stage to discuss the different modalities. So obviously there are multiple modalities that you, as you see here, to look at viability. But as Dr. Zoghbi mentioned, the sensitivity in this meta-analysis looking at multiple studies is highest with FDG PET. The specificity is highest with dobutamine echo. Now, I just want to draw your attention that as much as this, we like to rely a lot on viability, most of the studies are done on a small number of patients, and there have been a lot of variability among these different studies. So when it comes to randomized controlled trials, this is where some disappointment might come because many of these have had a lot of variability among these small different studies. Dr. Zoghbi also mentioned about the different modalities, so I'm not going to go over them, but in nuclear cardiology, we're going to focus primarily on perfusion and metabolism. So we have multiple tools to look at perfusion and metabolism. So if you want to look at perfusion, we look at cell membrane integrity, and we do that either with thallium or with tetraphosphine or MIBI based on technetium, and then we can use nitrate-enhanced thallium or technetium. And if we want to look at cell metabolism, then we look at FTG or acetate. FTG is the one that's FDA approved. Acetate is primarily used in research. And in addition to that, so if we start with SPEC, there are many protocols. So when you're reading a viability study on Funder 9, you need to know what protocol they use for that. So for thallium alone, there are multiple, technetium multiple, and then you have the combined one. So just make it simple for you here. So you have a patient with low ejection fraction. They come, the easiest way to do it, if you want to get very quickly, patient is very sick, you don't want him to be with you for a long time and out of the ICU. All what you do is you do rest injection of thallium, you image the patient quickly, and then wait 3-4 hours, rely on the redistribution of thallium, and just come back. You didn't test ischemia, patient is already sick, some centers are even doing it on patients on balloon pump. They have a mobile gamma camera, and then they can do it in some centers. That's kind of the easiest way to get a true viability assessment because you're relying on the sodium potassium ATPase channel to tell you that this cell is alive and it did take inside the thallium. Now, if you want to get more sophisticated, stable patient, then you do a stress test because there is no better marker of viability than the presence of ischemia. So you start with the stress test, then you look at the redistribution, you re-inject for your rest study, you image the patient after your rest study, and then you bring the patient 24 hours later. That's kind of the full option kind of SPEC thallium imaging. Now, if you don't have the availability or the luxury of waiting for full 24 hours and you want to get your answer quickly, you can give nitro just before your second injection, so just before your rest injection, and then eliminate the 24-hour. And studies have shown that if you use nitro, then you're able to get good results in here. Now with thallium, nitro is kind of a luxury, but for technetium, once we get there, it's some kind of a must because otherwise you miss viability. So this is what you see. So looking here at if you're having stress, there is a clear perfusion defect in the inferior septal. At 4 hours, it redistributed, and now we see nice viability there, and now it's almost at 24 hours, it kind of completed the ring and tells you that the inferior wall is fully viable in this patient. And the more uptake of thallium, the more viable. So we're talking also, we like always to think of viability as yes, no, but it is actually more of a spectrum. So the more that there is thallium uptake or technetium uptake or eventually FTG uptake, the more that there is chance of improvement of LV function after revascularization. Now moving on to technetium, because thallium is lower energy, you don't get the best images that you'd like because of the low energy and also the high radiation exposure. So we have been using technetium for a longer time. Can we just use the same protocol for that? And yes, it has been tested, and this institution has been one of the main institutions working between Dr. Memarian and the late Mario Verani working on this. So this is our regular stress protocol, but now before your rest injection, you have to give your nitro before your rest injection. So here it's not an option, it's not a luxury, you have to do it. And this is the work that has been done in this institution by Habib Da'i and Mario Virani, showing you similar to the curve that Dr. Zoghbi just showed you, that the more the viable myocardium, the more with the increase of system EB uptake, that there is more chance of having viability, similar to what we just saw with thallium. And the reason I'm saying that nitrate is a must here, this is a study actually also looking at this. So you can see here, this is without nitro and this is with nitro. And you can see that you can easily miss viability and underestimate it with technetium if you don't use the nitro. So it's a very important, and 40% of those that were called non-viable were changed to viable. So you need to know how you're doing this test. Now, when these modalities, looking at SPECT modalities, were tested in randomized control trial, we cannot give a talk about viability without mentioning this such trial. And this is a trial of ischemic cardiomyopathy patients looking at all-cause mortality. This is not a randomized viability trials, but there was an option for the sites to do viability testing in these patients. So not everybody from the 1,200 patients that were enrolled got a viability testing. SPECT was done in 471, dobutamine echo was done in 280, some got like both modalities. And when they looked at those that are viable and non-viable, when you look at outcome, yes, viability was associated with better outcome. But obviously, since this is not a randomized trial, we cannot just take the univariate data. We have to do adjustment. When they looked at the adjustment with the multivariate, these differences went away. And there have been probably more than 1,200 papers looking at why the STITCH trial is negative. So there are 1,200 patients, but probably more than 1,200 papers trying to explain what went wrong with this. So I'm not going to go with that, but I'll tell you these are like a summary of what possibly might have went wrong. Patient risk for surgery, the suitability of target, those sick patients did not get the viability, those sick it was the surgeon decision to decide which patient get revascularized or not, and completeness of revascularization, and the time to revascularization, LV size, concomitant mitral regurgitation. But one of the possible reasons is the viability test used. So in the STITCH trial, yes, they used dobutamine echo, but the bulk was technetium or thallium SPECT imaging. And I've shown you this case before. This is one of my patients who, looking at this, you will think that the LAD territory is not viable. There's a large scar. This is the thallium viability study, stress redistribution. And then looking at the same patient when he underwent PET, even with perfusion, you can see the amount of viability. And this is even 3 years later. So it is not possible that he was scarred and now he just like got stem cell transplant and got viable there. So this is One could say, well, this is thallium. Maybe if you have used technetium, you would have done better. Well, I searched in the literature, there is a similar case, system BB. And you can see the defect in here. And you can see that when they use FTG for this patient, there is significant viability that was literally missed by SPECT techniques. So as much as we think nuclear is the most sensitive, but technically it's PET that is the most sensitive, even from the meta-analysis. And in this study, they found out that almost 23 to 25% of segments were reclassified as viable by FTG PET, and they were initially called non-viable by SPECT techniques. So we've seen it often, and hopefully once we start our PET program, you'll see many of those patients that were potentially underestimated by SPECT imaging. So how do we do it with PET? With PET, we try to rely on the fact that normal myocardium will like free fatty acid. But when you have ischemia, it switches toward glucose. So we try to feed the alive myocardium that's hibernating, we try to feed it glucose, but not any glucose. We try to give it radio-labeled glucose by F18. So F18 is produced by cyclotron. It has a half-life of 110 minutes, so we can give us time to inject it. And then it goes inside the cell like glucose. Glucose goes inside the cell and goes in the Krebs cycle, if you remember this from your biochemistry classes. And then it got degraded into lactate or other biometabolites, but FTG, if it goes inside, just stuck inside the cell until it decays. So it gives us some time to image it inside the cell. And so how do we do it? These are the guidelines. We have to push the glucose inside. So for glucose to go inside the myocardium, you need to have insulin, even in non-diabetic. So all of you just had lunch, all of you had insulin going up. So now your myocardium is taking glucose that you just had from the rice and other carbohydrates. Now, after 4 or 5 hours, your insulin comes down and your myocardium is going to switch back to free fatty acid. So here, what we are trying to do is simulate the same thing. So we give the patient glucose, non-diabetic, we check their glucose, we give them glucotrol to drink, 25 or 50 or 75 based on their sugar, and then we just go ahead and inject insulin based on how much is their blood sugar. And you have to inject insulin. And if you have a patient who is insulin resistant, you have to give them a lot. My record is 72 units of insulin in a non-diabetic. Now, in the US, when I was practicing here, it was probably more about 10 to 12 units of insulin. So you have to know your patient. Otherwise, it is going to be challenging to be able to do it. And once you do that, you do your glucose manipulation. It might take 60 to 90 minutes, but may take longer in an insulin resistant patient, and then you inject your FTG. Now we're talking about 10 to 15 millicuries, but if you have a high sensitive camera, you can even lower it down to even 7 to 10 millicuries, and then wait 60 minutes and then image the patient for 15 minutes. So it is kind of tedious for the patient, but it does have to be done right, and then you'll get the best result with that. So when you do it, what do you see? So we do flow, and here you see that there is the anterior wall is almost missing, and there is no FTG uptake in there. So that's a match defect, and that's a transmural scar. Now here you see the anterior wall is missing, but it's coming back with FTG, and that's hibernation. That's what you want to see, and we call it a mismatch. Now Marcello Di Carli, looking at animal models, he showed that sometimes you get a normal perfusion, but the FTG is not well uptaken, and this could be either insulin resistant or could be stunning. So these are the two models. But sometimes you get a patient like this, which happened during my fellowship. I remember we went back and investigated what happened. You have a defect, and this patient actually has a perfusion defect in the inferolateral wall. We gave FTG, nothing went into the myocardium, it stayed in the blood pool. So we went back, looked at the records, and looked at it. Everything went fine. He got enough glucose. But then after we gave him the FTG, the patient somehow managed to get some glucose and had a good meal And then so we imaged it. There was unlabeled glucose in his body and the labeled glucose. And obviously, our dose is much less than what he got. So you have to be very careful about how you do this protocol because something could ruin your imaging and not be able to get your imaging techniques. So data have been kind of favorable for PET in a sense that if you do bypass surgery among patients who have PET mismatch, yes, they do better than those with medications, which was statistically significant. Among those without PET mismatch, so they have mostly scarred, then these patients, there was no statistical significant difference between the two. Now, this is not randomized data. This is observation data. And their ejection fraction actually does go up if there is more than 18% mismatch. So similar to the number that Dr. Quinones was mentioning. The more that you have of mismatch or viable hibernating myocardium, the more the chance of recovery in these patients. And again, very similar data from part 2 trial from the more that you see if there is large scar, so looking at it from the other end, if there is large scar, then you have the chance, there is very little chance of improvement of LV ejection fraction. And the cutoff actually for benefit from bypass surgery was about 10% mismatch size. So if there is less than 10% mismatch, the chance of recovery is much less. Now, this is looking at one variable. I always try to emphasize it. So if the LV is like 500 ml, you don't need 10%. You probably need 40% to be able to recover that LV. So there are multiple factors that you have to factor in. If the patient has severe MR, then you have to factor that in when you're making the clinical decision for recovery. So how did nuclear techniques, especially FTG PET, do in randomized control trial? This is probably the only randomized trial for viability. So they brought patients and they said, okay, you're gonna decide to revascularize, we're gonna do PET. Whatever the PET says, you're gonna do for these patients. And then we'll look at the outcome of these patients. So if we say there is not enough viability, just treat them medically. If there is enough viability, you take them to surgery. And the disappointment that there was trend, but not statistically significant among the two groups. So decision guided by PET was not significant. So we're gonna go here looking at the adherence. So the adherence was not as high. So in other words, yes, you're enrolled and the PET study said you should not get revascularized, but the surgeon decided to, or the interventionist decided to go ahead and revascularize the patient. Or sometimes there were still about 20 to 30% of patients in this trial did not adhere to the guidelines, to the recommendation by PET. So you do a viability study, but then eventually you're going to treat the patient the way you would like to do. And when they did this, another analysis looking at those that adhere to what the viability study did, this is now you get a statistical significance, and they just recently published the data as of 5 years, and you can see the difference is even getting more. So those patients who actually adhere to the FTG PET recommendation actually did better. Now, I just want to also guide your attention that the event rate is very high. These are sick patients. These are like cancer survival curves, right? I mean, you got a 5-year survival of about 50%. Now, this is a group of patients, no matter how you treat them, this is a very contemporary study, they're going to have a high mortality and high morbidity. And we need to look at multiple factors when we decide on the management. So I'm going to stop here and show you finally the last slide, the differences among the different modalities. I know Dipan was going to talk about delayed enhancement CMR, but you can see here that SPECT and PET, probably PET gets the most in terms of positive because in terms of sensitivity, it's the highest. Cost is obviously higher also, but validation data has been there for many years looking at different tracers. SPECT is widely available and it's probably still the most widely used one, but unfortunately, you end up underestimating viability in about 20 to 30% of patients. So with this, I'm going to stop and leave it for Deepan.
Okay, so let me, I think this is a very outstanding discussion because you're really hearing multiple different perspectives from the standpoint of different imaging techniques. And so what I'm going to try to do first, though, is let's walk back a little bit and just talk a little bit about what exactly is myocardial viability. I'm going to talk about how CMR assesses viability, show some data with regard to use of CMR for prediction of functional improvement, and then really explore some ideas that go beyond just functional improvement. So obviously, when we think about myocardial viability, as I think we've already touched on, we use a number of different surrogate definitions. These are all really clinical definitions, but I think if you really think about it, from the most fundamental standpoint, what is viability? It's probably really the presence of living myocytes. And non-viability is the absence of living myocytes. So I think, I like to think of it from the most basic, simplistic standpoint. That's really what viability is. Now, I think what's unique about CMR is, this technique obviously has been around for almost 20 years. And what it does is it gives you almost a direct match to what you would see histologically. So here's an example. This is really kind of the first publication in an animal model where the LAD was ligated and an acute infarction was created. On the left-hand side, you'll see the actual histopathology, and on the right-hand side, you'll see the corresponding MRI images. And you'll notice as we look at each of these individual slices, there's a pretty nice relationship between what we see as infarction by TTC staining and what you see as bright or hyperenhancement, areas that retain gadolinium. And in fact, if we take a look at one of these panels and blow it up, you can see that what you see as hyperenhancement or bright on the MRI almost exactly matches in 3D's contour what was seen at the time of autopsy. Obviously, the big difference is that we can do this MRI in living human beings. The histopathology is only really available to the pathologist. And quantitatively, in this animal study, there was a very tight relationship between the true size of the infarct as well as the size of the hyperenhanced region seen on the MRI. And this held true whether we're looking at imaging at 1 day after the acute infarct, at 3 days after the acute infarct, and even at 8 weeks after the acute infarct was created within the animal model. And in fact, you'll notice here, this is looking both at reperfused as well as non-reperfused infarcts, really showing that the relationship held true across both entities. Now, how do we do this in human beings? How do we do a clinical CMR scan to assess myocardial viability? So obviously, these patients need to get peripheral IV. They go into the scanner. We'll typically acquire a set of cine images, which allows us to look at contractile function, as well as ejection fraction and size of the ventricle. Inject gadolinium contrast, wait about 5 or 10 minutes, and then we go on to perform our delayed enhancement MRI images. So what's a total duration of time that's required for this entire study? It's probably about 45 minutes to an hour. So it can be done in a fairly quick fashion. And notice there's no stress agent that's required to perform this. Now, what does this look like when we do it in clinical patients, in human beings? So here's an example of a patient on the left-hand side. And again, these are some example images from the classic New England Journal publication from Raymond Kim. Here, this is a patient who had a known LAD infarct about 292 days prior to presentation. And what you'll notice in this patient is there's a large area of hyperenhancement all along the anterior wall and apex. And in this patient, we would describe it as really being transmural, almost encompassing the full thickness of the myocardium. Compare that to the patient on the right-hand side here, where you'll notice there's a small area of hyperenhancement in the RCA distribution along the inferior wall, but you'll notice this really only incorporates about a quarter of the thickness of the wall. And again, with the ability to directly anatomically image the infarct, we're able to go beyond just saying, yes, there's viability or no, there isn't, but actually to quantitate the extent of the infarction and the extent of viable myocardium. And then in this middle example patient here, who has a left circumflex infarct in the past, you can see a subendocardial infarct that incorporates about 50% of the thickness of the wall. Now, in fact, in this series, there were also patients who had very small infarcts. And if you look at this patient here in the middle, the peak CK rise was only 12. So very tiny evidence of enzyme release. Culprit artery was the right coronary artery, and in fact, you can see an area of hyperenhancement in this patient in that same distribution. Now, what are the reasons that we're able to do this? One is the spatial resolution that you get with CMR is very high. The pixel size here is about 1.5 by 1.5 millimeters. In addition to that, you'll notice that the contrast between the infarct and normal myocardium is also very high. It's almost a 5-fold increase in signal intensity in the infarct. And then lastly, obviously, there's no radiation exposure that's required either. So let's move on now to prediction of functional improvement. And again, this is going back to that classic New England Journal publication. And this study design was seen in DeBakey and echo studies as well as in nuclear studies, which is really you take a patient who has ischemic LV dysfunction, you bring them in to undergo cine MRI to look at wall motion, as well as delayed enhancement MRI to assess viability. The patient then goes on to get revascularized, either with percutaneous means or with surgical means. And then they're asked to come back at follow-up about 3 months later to reassess what their LV function as well as their regional function is doing, and really to try to see if there's a prediction or if there's an association between the viability in any given segment and the likelihood of improvement in contractile function after the revascularization. So I'll show you an example case, and here's a patient here who, on baseline imaging, this is a patient with multivessel disease, has an LV ejection fraction of about 30%, and we can see that there's global dysfunction, but there's some regional variation as well. On the delayed enhancement MRI, you'll notice there's an area of almost transmural infarct here, incorporating the anterior anterolateral wall as you go down to the apex, as well as some infarct in the inferior wall. But notice the lateral wall and the septum are relatively spared. And this patient, after revascularization, you'll notice the lateral wall especially, which had no hyperenhancement at all, you can see it very nicely on this 4-chamber view, really demonstrates a significant improvement in contractile function, whereas that area in the inferior wall and the area in the anterolateral wall, which had a pretty significant amount of hyperenhancement, doesn't show any improvement. And this patient overall, though, the improvement in ejection fraction, or the ejection fraction went from 30% up to 45%. Now, on a systematic basis, how did the results in this study appear? Well, what was found was essentially that there's this inverse relationship between the likelihood of improvement in contractile function and the extent of hyperenhancement within any given segment. So that for those segments that showed no hyperenhancement, there was a fairly high likelihood of improvement. More than 80% of these segments improved. On the flip side, for those segments with more than 75% enhancement, there was a very low likelihood of improvement. Essentially, none of these segments improved contractile function. And then I think what was unique here also was if you look at those segments with those patients with the segments, with the greatest amount of dysfunction. So if we only focus in on the akinetic and dyskinetic segments, the predictive values here, both positive as well as negative, remained and actually got stronger. And in fact, if you have an akinetic segment with no hyperenhancement, there was over 90% likelihood of improvement. And then obviously, if you have an akinetic segment with more than 25% or more than 75% enhancement, essentially zero likelihood of improvement. Now, in addition to that, what about from a global standpoint? Because again, we're taking care of patients, not taking care of segments. And so there was also a relationship that was seen here. When you look at the extent of the left ventricle that was dysfunctional but viable based on delayed enhancement MRI and the subsequent change in LV ejection fraction with increasing amount of dysfunctional but viable myocardium associated with increasing likelihood or increasing amounts of improvement in ejection fraction. And again, as we've seen with other modalities, if you use a 5% threshold to define a response, to say they're looking for a 5% increase in LV ejection fraction, that corresponded to about a 25% of the left ventricle dysfunctional but viable. So again, that number I think is really truly tracks with the pathophysiology, which is that you need a certain burden of dysfunctional but viable ventricle that's getting revascularized to be able to manifest an improvement in LV ejection fraction. Now, what's interesting is that what I showed you was data in patients with chronic CAD. So we're really looking at hibernating myocardium in essence. There's also data looking at patients with acute coronary disease. So these are patients that come in undergo primary PCI, and then got imaged within 24 hours after their acute revascularization for an acute MI. And even there, you see this very same relationship, which is that there is a decreasing likelihood of improvement on follow-up imaging in these patients. And what we're really imaging here is stunned myocardium because you've already restored blood flow to these segments. And in fact, on the right-hand side, there's a study we did a few years ago looking at patients with chronic heart failure who are not revascularization candidates. And even there, you can find that there's the same inverse relationship just with medical therapy, with beta blocker therapy and follow-up imaging. You find that as there's an increasing there's an increasing amount of infarction in any given segment, the likelihood of improvement goes down. What you will notice, obviously, is that medical therapy doesn't give you the same magnitude of improvement in contractile function as we saw with restoration of blood flow, and that's not a surprise either. So you may ask, well, how is it that acute infarct and chronic infarcts are very different pathophysiologies, but how is it that this technique is able to image anatomically both? And I think it has to do with what the speculated mechanism of gadolinium is, which is that in normal myocardium, the myocytes are fairly tightly packed with intact cell membranes. And as a result, there's very little room for gadolinium to distribute. And again, gadolinium distributes to the extracellular compartment. Now, if you look at an acute infarct, what happens? Well, you have now rupture of the cell membranes, and as a result, the gadolinium now is free to flow both in the extracellular compartment as well as within the myocytes themselves that are ruptured. So you now have a larger volume of gadolinium that can be retained within any given pixel in acute infarct. Whoops. And then lastly, in a chronic infarct, what you have now is a loose collagen matrix. And again, there's a larger volume of distribution for gadolinium in the extracellular space. And so as a result, what we're able to image is essentially the same thing, even though they're very different pathophysiologies that we're imaging. Now, let me look at one kind of special situation. And this is, we've touched on this already, which is patients who have wall thinning. And so for this investigation, which was published a few years ago, we looked at a series of patients, and I'll show you one example patient here who has really a large area of extensive wall thinning all along the septum. And this person on delayed enhancement MRI has complete transmural hyperenhancement along that thinned out septal wall. So extensive scarring as well. Compared to a second patient now who, when we do our cine MRI, you'll notice again, this person has significant LV dysfunction and has an anterior wall and apex that is very thinned out, measures about 4.5 millimeters, and is akinetic, so extensive wall thinning. But when you look at the delayed enhancement MRI, although we notice that the wall or the amount of black viable myocardium is in fact reduced, there's very little hyperenhancement as well. And so if you look at the ratio of the hyperenhanced to the non-hyperenhanced area, there's really very little scar. So the extent of infarction in this case is actually limited. It was only about 30% or so in this particular patient. And this, again, is looking at the thinned area specifically. Now, what happened in this patient after revascularization is very interesting. The ejection fraction did improve from 30 to 50. And notice what happened to the anterior wall. Contractility actually is now improved as well. And I think probably what's most striking is not only that, what's the thickness of the wall? 4.5 millimeters here. And now you have a wall that's returned back to normal, about 9 millimeters. So you've actually got not only reversal of contractile dysfunction, but you actually have reversal of wall thinning as well. Now, in this investigation, we looked at over 200 patients who had evidence of wall thinning by CMR and looked at what is the amount of scar within these thinned areas. And as was noticed in previous investigations, there is this inverse relationship that as the wall gets thinner, there tends to be a larger or extent of scar within the thinned area. But you'll notice on the scatter plot, there's quite a bit of variability. And in fact, what most predicts likelihood of improvement in these thin wall areas is, in fact, if there's limited scar present. And in this series here, for those patients that went on to get revascularized, systolic wall thickening actually improved after revascularization in those that had limited scar, but it did not improve in those with scar more than 50% of the wall thickness. And then in addition to contractile improvement, this also demonstrated, in fact, that regional wall thickness, so the thickness of the wall and end diastole, actually improved in those patients with limited scar, but remained flat after revascularization in those patients with extensive scar. So I think this is one example case where CMR could be very useful, is in those patients, or in identifying potential patients who may have reversible wall thinning. Now, how often did this phenomenon occur? Well, in this study that we looked at, when we looked at the number of patients who had evidence of limited scar, in fact, it was about 18% of patients who had less than 50% scar within the thinned area. And in fact, surprisingly, about 5% of patients, in fact, had less than 25% scar within the thinned area. So it's a small percentage of patients, but I think it's not an inconsequential number of patients. Now, these findings were a little bit in contrast to prior studies that were published in literature, including a CMR study, which actually looked at contractile reserve in patients with wall thinning. And this was actually a study that was published about 30 years ago by Jerome Bax, where they actually looked at patients who had wall thinning, did dobutamine CMR on these patients, and failed to demonstrate really the viability in these patients, despite the fact that the wall was thin. And why is that? I think it has to do with the pathophysiology that we're dealing with here, where you have wall thinning but still very limited scar, is a very extreme form of hibernation. And as I look back through our series, one of the things I noticed in all of those patients who had thinning but had significant or had limited scar, almost all of them had a total occlusion or 99% occlusion. So these are patients who have very, very severe reduction in blood flow, but for whatever reason they were balanced enough that there wasn't a full transmural infarct. And in fact, many of these patients had a prior revascularization in the past and had restenosis of the stent. So I think it has to do with this concept, which is that when we look at contractile reserve, what we're looking to see is either an improvement in contractile function and then a gradual decline, what we call the classic biphasic response. Or sometimes it's been described also, you can actually get this, what's called a uniphasic response, where you start out with hypokinesis, contractility immediately begins to get worse, and then it progressively gets worse afterward. And that's also thought to be a measure of viability as well. But then what happens when you're starting out in this extreme form with akinesis or dyskinesis to begin with, you're really not able to see a further reduction or deterioration in contractility. And so I think this is really kind of a special situation where you've got very, very delicate balance between blood flow and the need for blood or oxygen consumption, such that these patients are just barely hanging on. Now, let me move on to another, one study which has looked, again, observational data, looked at presence of viability based on CMR and likelihood of survival. So again, this is similar to data that was out there with other viability testing techniques. And in this study also, what they found, in fact, using the cutoff of more than 4 segments dysfunctional but viable, so again, about a quarter of the ventricle dysfunctional but viable, is that if you look at those patients who have viability, and so focus in on this curve right here versus this curve right here, the patients that got medical therapy or incomplete revascularization had worse survival than those patients who had viability and who got complete revascularization. And then obviously for those patients who did not have viability, really they fared about the same whether they got medical therapy or they got complete revascularization. So again, these findings are similar to what we see with other viability testing techniques, but yet still don't match up with what was seen in the Stitch trial. And then let me just kind of touch in the last couple minutes on a couple other scenarios where CMR can be helpful. And I think this is kind of the beyond functional improvement pieces of information that it can provide us with. So here's an example. It's a 60-year-old gentleman who comes in with an acute STEMI. He has a primary PCI to his culprit left circumflex. And what do we notice when we do MRI on this patient a day later is that he has actually what looks like an area of enhancement with the central hypo region in the middle here. What is this? For those of you that have rotated through the MRI lab, this is really an area of microvascular obstruction. So there's such significant edema and capillary destruction in this area that it just takes gadolinium a while to get into the center. And in fact, if we keep repeat imaging this patient, between 3 minutes and 20 minutes, you'll notice that most of the infarct eventually does fill in with contrast. So again, MRI is able to identify this microvascular obstruction, and there's data suggesting that this in and of itself seems to have prognostic implication as well, over and above the extent of the infarct. So obviously the size of the infarct is important, but if you have microvascular obstruction, that seems to be associated with reduced event-free survival. And on multivariable analysis, that was a stronger predictor, in fact, than infarct size itself. Now, another concept I want to touch on is the idea that how is the pathophysiology of viability? Is it dichotomous? You know, we like to have things that are simple, abrupt cutoffs and that are dichotomous definitions, but the reality is it probably doesn't exist this way. It probably is much more like this, which is that there's a gradual linear relationship, that as there's increasing viability, there's going to be increasing likelihood of improvement. And so I think what we need to keep in mind is that when we deal with these segments in the middle, when we deal with these patients that have intermediate amounts of viability, it's easy on the edges, zero infarction or 100% infarction. But when we deal with the patients in the middle, we really need to kind of integrate everything together. The amount of segments that have intermediate amounts of viable myocardium, as well as what the overall risk for this person to undergo revascularization is. And then let me kind of be provocative and put out there another concept, which is that, although most studies tend to try to look at functional improvement as kind of the standard of truth, the reality is that we know that in and of itself is limited as well. Why is that? Because we know that in clinical practice, all patients don't necessarily go on to get complete revascularization. Maybe there's downstream lesions beyond where the bypass graft was put in. Maybe there's arteries or small vessels that can't be bypassed, so there's a variety of reasons. Some patients will have recurrent events between the time of the revascularization and the time that you do follow-up imaging. You can also have, we've seen this phenomenon where there's extensive scarring in one area next to an area of viable myocardium, but that can then lead to tethering and prevent us from being able to demonstrate an improvement in contractile function in the adjacent areas. And then I think another important thing to keep in mind is what's the optimal timing from which you revascularize to when you do follow-up imaging. And this actually was a nice study. This was looking at patients with chronic total occlusion, but they actually managed to image these patients at 2 time points. One is at 5 months after revascularization of the CTO, and then another is at 3 years later. And what they found is that for those patients who had less than 25% enhancement, or for those segments, they saw improvement in contractile function by the 5-month follow-up scan. And then there was progressive further improvement when they came back for the 3-month follow-up scan. But notice for those patients who had 25 to 75% enhancement, essentially those with intermediate amount of infarction, on the initial 5-month scan, they did not demonstrate any improvement in contractile function. But when these patients came back at 3 years later, now you began to see an improvement in contractile function. And that's where there's also DeBakey and echo data suggesting, in fact, that if you look at contractile reserve, so you give these patients inotropic stimulation, some of these segments that you thought did not improve may actually show improvement with inotropic stimulation, or as this study shows, may show improvement if you give them more time to manifest improvement. Okay, so let me wrap up here. Now, what are some special considerations? I think a couple of things to keep in mind, however, is to do delayed enhancement MRI requires administration of gadolinium contrast. So in patients with renal insufficiency with a GFR less than 30, that may be a limitation. Also, I get asked this question quite frequently. We use this iron-based agent for vascular imaging, ferumoxytol. Can it be useful for viability imaging? And the answer is no, because it does not have the extracellular properties that gadolinium contrast agents do. Other things to keep in mind, what about patients who have implanted devices? So pacemakers are generally not an issue as far as imaging artifact. If you have patients who have ICDs, sometimes if the ICD is fairly close, the generator is fairly close to the apex of the heart, that can cause artifact. And also you need to make sure that you use specialized imaging sequences that are designed to minimize the artifact from devices. And then lastly, BIV ICDs can be challenging for viability assessment. And then importantly also, patients who are hemodynamically unstable. So if you have a patient on a balloon pump MRI is not a good answer for that patient. So let me leave it there and wrap up, and I want to get the other speakers to come up for questions. But I think CMR, I think, is nice, and that's uniquely able to image both viable as well as non-viable myocardium. It's able to do so without the need for a stressor agent, and it's able to predict likelihood of improvement in contractile function, both in the setting of chronic CAD, acute CAD, as well as in chronic heart failure patients undergoing medical management. So come on up, and this is now, I'd like to open it up for questions, Dr. Q.
Yeah, a clinical question.
Can you use?
Oh, microphone, yeah.
Yeah.
Yes.
A clinical question. The scenario that we most commonly use is the chronic disease scenario, bad EF patient, shouldn't we? And that scenario, I think, has been covered very nicely throughout the entire presentation. You presented some nice data, and I think in the echo world, we also had some, I'm sure you have it too, in the acute scenario. My question is more practical. In the scenario of an ACS, when do you think, in what clinical changes in a patient should prompt a viability assessment? I mean, patients routinely come with ACS, we take care of them, we stent them, give them drugs, send them home. What would be the scenario in that setting that we should say, oops, we should take a look at viability, regardless of the test? That's just a general question from the point of view of clinical practice.
It's a difficult one.
So one situation that I had was late presentation MIs. So in the Middle East, about 33%, we published on that, 33% of acute MIs come in more than 12 hours of symptom onset. You take the patient to the cath lab, he already completed his infarct, he's symptom-free, and now he has 3-vessel disease. So it's always the LAD. So if you're gonna do cabbage, you're gonna revascularize the LAD. But if the LAD is not viable, then you can just go ahead and do PCI of the circ and RCA and call it the day. So that kind of the situation where viability is used to differentiate, to not to decide whether to revascularize or not, but to choose the mode of revascularization. Cabbage including an LAD versus just PCI of RCA and circumference.
So patients that come in too late, that would be one scenario. Okay. Any others? Thoughts? Any other?
Okay, I mean,
Once you have stented,
Yeah,
exactly.
when they're
I mean, the big concern in viability in those areas is when you have a no reflow phenomenon. I think what Dipan has mentioned is in the MRI world of how does a no reflow phenomenon would look like. In the cath lab, obviously, it looks like a low flow situation in an open artery. In contrast, it will look like a contrast defect. And what do you do in those situations? I mean, there have been some pharmacological, alterations of that. But I think that's another area conceivably that tells me about it. But are you going to do anything different about it? I'm not sure. I think Mouaz's scenario is certainly much more applicable. Any other questions? Man.
get a microphone.
I always have a question about viability. When you read a study, do you think you should be aware of what the cath shows, or do you think you should go completely blind and then take a look at the cath? And how do you think that impacts all these studies and how they were done, I think?
So, I mean, I can tell you, so I think there's two things. One is, obviously, you want to look at the images yourself, make an assessment. When you give the final assessment to the clinician, I don't think clinicians want to see a 17-segment bullseye plot where you map out the amount of enhancement in each one. They want you to integrate that information and put it together to help them make a decision. Is the LAD territory viable? Is the RCA territory? Is the circ territory? So what I do is before I give the final assessment to the clinician, I try to integrate all this information together. I think it's easy for us to just describe what we see, but again, that's not what the clinicians want. I mean, I think what clinicians want is for you to integrate the information, which takes into account the clinical history as well as the cath findings, to try to basically say, okay, if I revascularize this lesion, is there likelihood of improvement or not? So that's kind of my approach.
My approach is always try to minimize bias. number one, you read the study the way it should be read. If it's a viability study, I'll look at the viability. Whatever characteristics you're looking at, et cetera, et cetera. Just then conceivably you can put it in the context. Most of the time you don't look at the angiogram. I think the clinician has to put it together and say, where's the area of dysfunction? Does it go along? Because the heart would remodel, and you can have actually hypokinesis in an area that is epicardially perfused well. We don't know at the microcirculation. But the clinician will have to put the angio together with the viability assessment and what you could do, be it catheter or get another study even to try to understand what the situation is, particularly if the risk is high.
So I think in your report, it's fine to report segments, but as Dipan mentioned, clinicians, especially in the heart team discussions, they want to know lesion. So I'll give you a scenario. You see a distal LAD infarct and there's a proximal LAD lesion. And they will tell you, if we open up that lesion, so they want to know about that lesion specifically, or if we bypass this vessel, especially in cases where the RCA versus or OM kind of lesion. So there is an RCA lesion and there is an OM lesion. Which lesion should I open? Is this territory viable or non-viable? I think in heart team discussions, it's going to come down to whether this artery beyond this lesion supplies a viable segment or non-viable segment.
But ultimately, because the imager is not, most of the time, not going to have the angio data, because at times the angio data follows or precedes, depending on the situation. And it is imperative on the clinician to even look at the data and see whether it fits a certain pattern, yes or no, to make a decision. Other Faisal.
Quick question for Mouaz, since you do all three modalities. Have you had a case where, is it easy by PET to say, okay, I don't think I got enough insulin on board and maybe I'm not as sensitive and therefore I'm going to push on to MRI or?
Well, I mean, we've done about 800 FTG viabilities in the past few years, and I had few failures, but they are like already patients on 50, 60 units of insulin before you. So you know, but the patient had renal failure, they don't want to send them to MRI, so Ken's like, please do it and give it a shot. So kind of situation, so you can try to push it, but the key here is that to push as much insulin as you can. But you know that in those extreme insulin resistant patients who are already a lot of baseline insulin, it may not work. So this is kind of the only caveat that I would have in there. So I'll try to push them to start with MRI. In fact, our rule over there, because MRI was kind of more available, if you want viability, get an MRI. If there is no MRI or there is a contraindication for MRI, we'll get them to PET, because our PET was kind of much more busier in there. But in other centers, they start with PET, and then you can get with MRI. And by the way, many patients, you will need to do two studies. I mean, I showed you data from the STITCH trial. There are still some patients who got both. I always err on the side of the benefit to the patient. So especially when they're denying a young patient, 40s or 50s, revascularization, I want to be sure, because many of these studies have false negatives and you may underestimate viability. So to deny somebody a potentially life-saving procedure, you have to be very sure, and sometimes you need to do it. So if you're not convinced of your PET study and the quality of the images or the insulin resistance, then you probably need to go for another study.
And at times, if you have the typical nuclear, actually, we had a case in the New England Journal of Medicine many, many years ago, where respiratory distribution thallium was cold black. I mean, no perfusion whatsoever. So it depends on how bad the resting perfusion is that it may alter many of these tests. Probably not as much gadolinium enhancement, but if the perfusion at baseline is incredibly low, it starts interfering with contractile reserve, respiratory distribution thallium, and many other things. So not every test is 100%, neither positive nor negative. So you're going to keep that in your mind, depending on also the likelihood of viability, yes or no. All right, and with that, I think, thank you all. Right.